Hi, this is Michael White, and I wanted to cover the front end process, which is a stair step kind of approach to medicine with the providers leading. I think in far too many departments, providers have relinquished their role, and as such, nursing has stepped up to fill that void. And in this process, the providers need to be the lead in the process because we are the reason that the patient. So, in my opinion, people come to the ER to see the provider. Therefore, anything that impedes the provider establishing a patient provider relationship is non value added. Consequently, I'm going to look at the very front end first, and we will talk about EMS later. But a patient comes in, they see the greeter. The purpose of the greeter is to put them in the computer. That's it. Once they're in the computer, they need to see the provider. Depending on the volume, you'll have multiple triage rooms. So, for example, let's take an ER of 60 visits a day. You have a period of time when there's a mid-level there, usually in the afternoon, and you would go to two triage rooms, one with a mid-level provider and one with a physician. In that triage room, the provider will do everything, meaning that they will have their provider station there with their computer, ability to see PACS, dictaphone, ability to print prescriptions, discharge paperwork. The area in the back, which a lot of people refer to as the doc box, will become non-functional because there's no need to be back there. The reality of the situation, there's a famous book that discussed about being, if you manage the 80%, at our contracts, closer to 90% of patients come through our front door. We need to manage the front door. And we need to be the ones to lead that. How do we do that? You lead from the front, not from the rear. So we'll be stationed there at the front. So the patient comes in, sees the greeter, the room that's available, the patient will go into. So this is always a little bit of a point of contention because if you have two providers on, one provider will often say, I saw the last one, so I don't want to see the next one. It's not how it works because you don't know what the other provider is dealing with. Let's take a physician who's just told a patient that their loved one has cancer, and you're having conversations with them or with their primary about follow-up, and you need to be on the phone, then that's not a time that you need to be taking a new patient. Let's say their mid-level's off suturing, then the provider would take multiple patients. At the end of the day, I like to build an incentive model, and I'm working on this, where part of our incentive is patients per hour, and this encourages folks to continue to see patients because you got to get your total number in a given day to be able to get the bonus is a monthly average, but we'll discuss that more later. So patient comes in, multiple entry points, sees the provider. Now I can tell you this is how I like to do it, which is not necessarily how you have to do it. My wife is a practicing ER physician as well, and she certainly does not do it the way that I do it, and multiple other people have done it in different fashions since I've had this at so many different places, and it doesn't mean that there's a right or a wrong, but I'm just going to tell you my way. My personal opinion is the greeter puts them in, they pop up on the board, and I pop out of my seat and go to the waiting room. I greet the patient, get whatever paperwork from the greeter, and I escort them back into my triage room. Do this for a few different reasons. One, I'll be honest, I want to see as many patients as possible, and if I go get them, that means nobody else can get them. Number two, I am always cognizant of patient experience, and if I go get the patient, I establish a relationship with them, and also I set the expectation that I'm going to lead their care. Number three, it's also generally very impactful for the patient to have a physician or provider come out to triage to get them, and I like to set that they're going to get the highest service possible. So after I get my patient, bring them into my triage room, what I personally like to do, and again, this is my preference, is I like to ask all the nursing triage questions. Again, doesn't have to, every provider doesn't need to do that, but I like to do it. I learn what the nurses need to ask to put in the computer, and then I just run through the questions. I've even gone as far as posting them on the wall behind where the patient sits so that I can run through the questions and ensure I'm checking off everything the nurses need to know. And as I do this, the nurses are putting the information in the computer because that triage has to be put in as it facilitates everything downstream. Again, this is a personal preference for me. I like to put on the blood pressure cuff, the pulse ox, get the temperature as I talk and evaluate the patient. I believe that this increases patient experience. I also believe that this gives them the perception that I'm spending more time with them, and it allows touch and evaluation as I go along. Going back to asking the triage questions, a lot of people think this is low yield. I found this to be exceedingly high yield because there's a lot of information that I get from the patient just by going through their triage questions, which are pretty simple. Height, weight, allergies, pain scale, if they're a lady, when was their last period, medications that they're currently taking, past medical history, past surgical history, smoking, drugs. It's relatively straightforward. So I like to do the vital signs. Nurse types them in the computer. I discuss with the patient in front of them what they're there for. I do a brief evaluation. Obviously, if it's more in depth, like a pelvic exam, or they dislocated their shoulder and they need to go to a room for conscious sedation, then there's additional steps behind that. But I generally get all the information I need, I'd say north of 95% of the time right there in the triage room. And then I discuss with the patient what I want to do. What's interesting is that the patient tells one story in this model because the nurse is there hearing it and putting it in. Additionally, there's a lot of times the patients will say to me, I'm here for chest pain, and I'll say, well, I want to do X, Y, and Z. And they say, well, look, all I want's an EKG. I don't want all that other stuff. I don't want blood work. And then I just document that. The nurse documents that, and we aligned with what the patient's desires are in terms of their care. Also, I set the expectation of, hey, I'm worried you got a kidney stone. I'm going to do urine and get a CT. I need you to pee before anything else happens. Consequently, my arrive to urine collection is very short because patients, especially potentially pregnant patients, I let them know they either pee for me or they are the slowest step in being able to get back out of the emergency department and go home. And it's amazing how often they'll be able to give me a urine specimen after I have that discussion. But I set the expectations with them, discuss the estimated throughput time, ask them if there's any other questions, and I do that all there. It takes, depending on the acuity of what they're there for, 5 to 10 minutes at most. So after that, the patient is going to go to the next step. Now, in the back of my mind, I'm doing something that's called breaking the patient into sick and not sick. So this is a summary of what happens to a not sick patient. So the question is what is sick and what is not sick? It's pretty self-evident. Somebody that is pericoding or coding, respiratory distress, time-sensitive thing like a potential acute stroke, STEMI, those are sick. Those go directly to a bed, they bypass, and all it is communication with the charge nurse and the triage nurse. Very often I communicate with the triage nurse who communicates with the charge nurse. However, the gold standard is to have the charge nurse directly outside of the triage room sitting there so that communication can happen. Just like us, where the bulk of patients come through the front door, the charge nurse needs to be positioned where the bulk of patients is, which is the front door. So let's talk about not sick. And again, there's EMS, and I'll talk sick later. But EMS comes in, they get a brief triage in the back. If they need to go into a bed, let's say they can't stand or they're bed bound or they're psychotic or whatever it is, they dislocated their hip, then those are sick patients. Those are not sick patients. But assuming they're not sick, so somebody with some vomiting, headache, whatever they call the EMS, maybe even lacerations, they're going to be directed through the front, and the reason being is the front process is going to be most efficient. So our not sick patients is going to be close to 85 to 90% of all the patients that come through the department. Of EMS, at least 50% of those do not need to go to beds. So they come in multiple triage rooms with multiple contact points, and then they go to what's called the care area. The care area is described a little bit further later on, but essentially is a centralized area where you'll have techs. The techs do IV and blood draw. That's all they do, IV, EKG, and blood draw all day long, and get those specimens collected and off. CT, X-ray, ultrasound can grab the patient there. My preference is as early as possible to get my CT and X-rays because those are usually actionable items, and also there's a built-in delay to getting an official read, and registration can grab the patients there. There is, what you're noticing is there's not direct bedding going on. The vast majority of our patients don't need to go to a bed. Putting them in the bed gives them the signal that they're going to be there for a long period of time, which is not what we're doing. We're evaluating and moving the patient on. I'll have another video about how to think about patients when they present from a provider standpoint, but our goal is to get them seen, rule out emergencies, and then either get them admitted, transferred. Let's talk about EMS for a second. EMS arrives in the back, and again, we're not using the dock box in the back, which is stationed by EMS. The reason being is 90% of our patients come through the front door, so why wouldn't we be where the action's at, and the action is where the patients are, and that is the front door. So EMS comes in. Patients are broadly placed into two categories. Typically, this is done either by the by the charge nurse or a provider, and since the providers are sitting in the front, there is an EMS radio at the front so the providers can hear what is coming in by EMS. Anyways, let's say that a respiratory distress from that intervention. For those patients that are sick, everything goes to the patient's bedside, and that is where focused care happens. And again, those are for your hip dislocations, your septic shock, your patients coding or nearly coding. Everybody else, essentially, we're running through the front, and I want to point out that it doesn't matter if they're being admitted or not. That doesn't define sick or not sick. What defines sick or not sick is their ability to go through the triage process and the acuity of their situation. There is a lot of patients that will go through the front end process, and one I can think of is for example, a chest pain or somebody that needs a blood transfusion. They don't necessarily need a bed. What they need is, for the blood transfusion, you need the hemoglobin. For the chest pain, you need the EKG. So the nuts and bolts of how this works. To the right shows the greeter and triage. Patient comes in, gets a provider with a provider, and it can be a nurse or tech, whoever can put the information in the computer, pairing, and then there is getting the immediate area right after that to get blood draw, IV, EKG, X-ray, CT. I call it a care area. It doesn't need to be a designated area. It can be a modified patient room, whatever it needs to be. The bottom line is patients can't get out of that immediate triage area until those tests have been collected. Once that has been collected, then they can get over registration. There is not a lot of bedside registration in this model because the patients can either be caught by the registrar close to the care area, or they can go out to the lobby. Of the patients that do go to the beds, the registrar will need to go to the beds and do bedside registration. And then a decision is made once we get our results back, and we are going to admit based on the results, or we're going to discharge based on the results, and they can head out. So again, looking at the care area, multiple different things happening to the patient. The patient is kept in constant motion. It's kind of along the Disney model. You always know the next step, so you're not sitting there waiting. So looking at kind of a breakdown of, let's say you get somebody that needs a CT scan, that's going to take priority. Next priority would be plain films, then would be lab, EKG, and point of care testing, if we have that. And then finally, after that's obtained, and let's say the patient goes to a bed, that's when bedside nursing and registration would happen. Otherwise, the nursing would get them the medications or whatever they need back in the care area. Care area is for critical analysis and rapid evaluation of the patient, and it needs to be patient-focused, patient-centric, consistent, and the patient has to continuously be moving. So let's take a scenario where we have a longer step, such as obtaining a CTA of the chest for a PE. There's some critical things that need to happen to be able to get that, and you need to address those obstacles up front. So to get a CTA of the chest, Although I don't think it's necessary, a lot of radiologists want you to get a pregnancy test. So if that has to be obtained, then tell them you got to get pee right there in the triage room. If not, they go to the IV station where the tech does the EKG, places the IV. You can't do a CTA without the IV. If testing is needed, then the blood is in the lab. If not, then the patient directly goes over to get their CTA done. Once the CTA is done, then your other interventions are done, be it, let's say, a breathing treatment, be it you're going to do x-rays or an ultrasound or something like that. But the CTA is your critical action step. You want to know if they have a PE or don't have a PE or a dissection, and that is the critical information, so that is prioritized. So what are the drivers of making this process successful and delivering successful care? First and foremost, of course, is provider-patient care. Nothing gets in the way of that. We focus on discharges. This is turning the tables, because at most places you focus on admissions. But if you get your discharges out, then your resources are available to take care of everybody else, and it disimpacts and offloads the emergency department. Another way of saying this is folks who require few tests should not wait behind folks who require multiple tests unless you have somebody that is coding. You have to have a consistent process, and again, I like to look at the lowest acuity patients and see how we're doing, because if you can manage the basics well, then you can do well. It's kind of like in football, blocking and tackling. I'm a Florida Gators fan. They've struggled with blocking and tackling in the last few years, which are the basics to football, and consequently their record demonstrates this. Hopefully this year will be better. And then the next thing is the providers are responsible for focusing on patients. The charge nurse is responsible for managing flow through the department. She's the one she knows where the resources are, she knows who's busy, who's not, who can take another patient, who can get things done quickly. So ultimately the charge nurse is in charge of flow of the department. So I have discussed previously in another video about overall metrics, and I do have a video on specific provider metrics, but for nursing, what I like to look at is when you put up your discharge to when the patient departs. The next part is when orders put in until the specimen is received in the lab, and this can be urine or blood. Obviously, swabs should be collected directly there in the triage room. So if they make all that stuff happen, then things move forward. The other part is nursing can either facilitate radiology or obstruct radiology. My opinion is we need radiology early because that's actionable items. Things like EKG, if there's a STEMI, actionable item. Chest x-ray, if there is a pneumonia, it may prompt you to go down the sepsis pathway. If there's a pneumothorax, you need to do something. If there's large PE or dissection. So radiology needs to be prioritized. Going to radiology, my opinion is I like to look at certain specific radiology numbers. A lot of people look at global. I don't have this yet, but my goal for an extremity x-ray, and that's ordered a shot, is that O to S, and I put in there no pregnancy tests. So I like to look at those ones. Let's say me. I'm a 50-year-old guy, come in, I'm where I broke my wrist. There should really be no delay. That image should be shot in less than 15 minutes after the order is put in. Similar for me, I come in worried about a kidney stone. That image should be shot in less than 20 minutes. Registration, I like to look at the low acuity, which is the ESI 4s and 5s, and they should be registered within 15 minutes after triage. Triage is defined when the nurse completes her triage into the computer. It's not when they walk into that room. And so for those lowest acute patients, the sprained ankles, the prescription refills, that low acuity triage to registration needs to be less than 15 minutes. So what are we looking at? Overall global. And a lot of this goes back to the provider and a provider-driven process. Arrive to greet, less than 5 minutes, should be closer to 3 minutes. Low acuity length of stay, that's a composite of 4s and 5s. Really, that should be less than 40 minutes, but a goal for excellence will get us less than 50 minutes. Overall for the department, less than 90 minutes, and greet to admit disposition, of less than 100 minutes, and I have another video discussing that, but that's kind of a composite. Thank you so much for your time.